I'm Anton Pozniak. I'm a HIV and infectious disease physician from London, and I'm a consultant to virology education.
Hi, I'm Kiat Rakrungtham. I'm a professor of medicine at the School of Global Health, faculty of medicine, Chulalongkorn University, and also at HIPNET, Thai Red Cross AIDS Research Center as well, Thailand. Adeeba.
Hello, everyone. I'm Adeeba Kamarulzaman. I'm a consultant infectious disease physician at the University Malaya Medical Center in Kuala Lumpur and current president of the International AIDS Society.
Nittaya, please.
Hi, everyone. My name is Nittaya Phanuphak, and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, in Bangkok, Thailand.
Hi, Chien-Ching, please.
Hi, everyone. I'm Chien-Ching Hung from Taipei, National Taiwan University Hospital. I'm an attending physician at the Division of Infectious Diseases of the Department of Internal Medicine of this hospital. Thank you.
Jun Yong.
Hello, everyone. My name is Jun Yong Choi. I'm a professor of Yonsei University College of Medicine in South Korea. I'm an infectious disease physician in Severance Hospital. I'm very nice to meet you.
So I think the topic that I like to start with is the based on the presentation from Adeeba, that in this region in Asia Pacific, the patients, HIV patient in this region still show up quite late. So it's up to 55% of people show up with CD4 lower than 200. And from the IS conference, it looked like quite a number of data showing cell testing, digital cell testing is interesting. So the question is how this region can do better on the early diagnosis with people, not only from the cell testing, but any other strategy we should be thinking of. Yes, please.
In Korea, the hurdle for early diagnosis, one of the hurdles for early diagnosis is strong stigmatization for HIV infected persons. Risk populations such as MSM group do not want to get HIV diagnosis because of very strong stigmatization for HIV infection. So we should improve that problem. I think so. In this region, compared to Western countries, in Asian countries, the stigmatization is more strong, I think.
Okay.
Yeah, so if I can maybe follow up on the point of stigma discrimination, which I completely agree is the key barrier to many great interventions that we have right now in terms of the tools to end HIV in the next 9 years. HIV testing is certainly the entry point to everything, but we cannot say that stigma and discrimination do not have any roles in PrEP or ART initiation uptake. So for us in the country, I think what we have been trying hard over the past almost 7 years now is to use to put key populations at the center of the design of the service delivery. And this is what we call the key population-led health services in the country. And since we started the implementation, we have seen a double number of HIV testing uptake among our key populations, which mainly here I meant men who have sex with men and transgender women. So I feel that, yes, it is certainly true that we will still need to implement like multi-level strategies to address stigma and discrimination, but kind of like a short-term strategy could be something in a way that we establish an alternative service delivery options for our key populations in the region.
Yeah,
So,
if I can chime in there, go on, Anton.
no,
Yeah,
please do.
Yeah, some of the studies that I reviewed from the presentations at IAS certainly speaks to the points that Nittaya has brought up. I think there were two large programs. One's called Atlas, the other is called STAR in Africa, and certainly the points that Nittaya was saying around community-based programs to encourage self-testing and multi-sectoral involvement. It's also very important with the private sector involvement, but I think community-based program is the way to go, especially in Asia Pacific, where in terms of new diagnoses, 90% are amongst key population as well. So one of the ways to overcome the barriers is not just digital, but also peer-led, as you mentioned.
So I just wondered, looking at all of this, I mean, it could be done for any place in a way. It's about what the size and the regionality of this late presentation is. And then what are the drivers of it? I mean, we've heard, I think we've heard quite a bit already today about what the drivers are. And then the different approaches to overcoming this issue of late presentation. And already there have been several models of care discussed this morning. And because I think a lot of clinicians often just sit there and just go, well, you know, they're late presenters, rather than really get to the core of what can we actually do about it in our individual clinics or as a region or as a country. And I just wondered whether or not this whole area that we're discussing now could be put into a very nice session, which is giving tools, you know, information first, knowledge, facts, and then tools to people listening about how they might actually go about tackling the problem.
Yeah,
Certainly.
Yeah, one thing that I can probably share, according to the point that Anton just mentioned, is that it's also what people, I mean, in public, know about the services available after HIV testing. What we have seen very clearly is that the key population-led health service may be one thing that brought people in earlier, and we found that the median CD4 count of those newly diagnosed is like 350 to 400 compared to like less than 200 in most of the hospitals in the public health system. But at the same time, it's not because it's big, the providers are those who are key populations themselves, but it is because they advertised to their clients quite clearly that it is always good to get HIV testing, because if you tested negative, PrEP can be started on that same day. If you tested positive, ART can also be started on that same day. So like people know what to expect, and it's not like they as in the past, the people always wait until they have something to come for testing, hoping that it could be positive and then to get into treatment. But here, it's like different thing. You can come here, hope to be tested negative, and then be put on PrEP and other prevention strategies.
Yeah, that's right. So I think all of us also, particularly in Tone, said that it's probably need a specific session to really address this one and bring people more targeting way approach to try to see that how we can do it. You know, instead of just have a meeting education only. I think that sharing the expertise and experiences. Yeah, because I think most of the hospital doctor and nurses, I don't think they they probably have been overwhelmed that, if we rely on the hospital-based screening or diagnostic, I think it's very unlikely to achieve the goal.
Yeah.
Anything else from Taiwan and Korea before we move on to another?
In Korea, public health center performed important roles for HIV diagnosis in the past years, but recently, due to the impact of COVID pandemic, their work of public health facilities are focusing on COVID pandemic responses, so it make more harder to make the early diagnosis for key populations. So it's another concerns in terms of the late presentation problems. So I expect a few years later, this problem can be more worsened than these days.
Okay. Yeah, from the presentation by Jürgen, it looked like maybe Anton can confirm it and address. So what the main reason in the last 10 years that the new case incident increased almost, almost double, like it's about up to 60% increase from 110K to 170K per year. So is that any special reason? What he addressed is the stigmatization is a problem. Is really the only issue of that?
Yeah, I mean, if you're talking about Europe, obviously there's so many, and it's the same everywhere, I suppose. There's so many factors involved in this.
Yeah.
And including, of course, in Europe, migration. And we have to also worry about the impact of the COVID epidemic on what's going on with this issue. And I think that we were reaching a really good place in terms of our testing campaigns, because we had indicator conditions for testing. We destigmatized testing. There was a lot of European push to get people done. And I think that this has really deteriorated in the last couple of years with the COVID pandemic. And I think we've very much concentrated on trying to maintain, and I just wonder whether this is the same in Asia, trying to maintain those people on treatment, whether it be treatment or PrEP, keep them on it, rather than our focus being on let's try and get the early diagnosis.
Yeah, I see what you mean. Right.
You're right.
Okay.
And I don't know how well that's been measured, but I fear that we're seeing a lot of late presenters now. And I just think people have sat at home, and before, their opportunities for testing were huge, especially in UK and Europe. Right. You could get tests in lots of different situations, and there was a big family doctors were also getting more aware of doing this stuff, but family doctors have stopped seeing anybody for 2 years basically. Yeah. So we've had, and casualty departments, even people being admitted for COVID are not having HIV tests. I mean, it's incredible.
Right. Yeah.
And but patients, individuals themselves, certainly if they have no symptoms, don't want to go anywhere near a healthcare facility,
right? Rightly
so, for fear of getting COVID. Yeah.
Now let's move on to another topic a bit related. Is the same-day ART, because same-day ART also have a lot of stronger evidence from many studies showing that this should be the right way to go, right? Now I'd like to hear that what the situation in this region, and can we do better? How can we do better?
Well, I've seen some of the data that's come out of Asia, but there's also data out of South Africa, which wasn't so
Oh, yeah.
wasn't
Yeah,
so
different,
good.
yeah, different setting. Yeah, yes, I see
Yeah,
what
the
you mean.
different setting. So
Yeah,
I think that the trouble with that data is they didn't really tell us why. Apart from there's a lot of loss to follow up and etc. etc. So maybe that's the key here, that you could show the data and say, how can we make this work for everybody, every clinic? I mean,
right.
we make so much work for how can we standardize this approach and also not just do it, but know where the problems are down the line with it. And I just wonder, again, I wonder whether this whole bit about the conference should be have a whole section of giving a toolkit to everybody in clinics to be able to go, I'm going to do that tomorrow. I'm going to start this initiative. I'm going to really get it going.
Nittaya, you're probably the expert on this in this panel.
Yeah, I'm glad actually to hear more of the same-day ART wording being mentioned more frequently or like with more confidence, at least in our country. And I also have to thank Professor Kiet for being behind the effort, putting the wording, the same-day ART, and not just rapid ART initiation into our guidelines, into our national guidelines. And I think that really helped a lot, at least for Thailand, because just like before, we have this mentioned specifically in the guidelines. People will see same-day ART as something that only just like special clinic can do that. But with the guidelines and with probably sort of like the tools that Anton mentioned, that we put the kind of example clinic flow on how to do same-day ART initiation in different hospital settings, like small hospitals, medium-sized hospital, university hospitals, something like that. That really help people to like visualize that this can actually be done in like several settings with probably various challenges. And I feel that this is something that at least can initiate discussion among like the actual implementers in the field. And the one thing that we also learned quite clearly is that same-day ART initiation in any hospitals really need a doctor to lead the kind of the revolution of what you have been doing for 30 years, and now you are going to do something new. and like ART effort in Thailand usually is driven by nurse, but for same-day ART initiation, you cannot just have the nurse who want to do it and you can do it. You really need a doctor to lead this revolution. I may use the wrong word, but it is actually something that you need that level of change. Yeah.
Okay. Any experience on other countries?
Yeah, but probably I can share some experience with same-day or rapid ART initiation here in Taiwan. A Taiwan CDC requests us to start antiretroviral therapy within 7 days of diagnosis since 2018. So it's the proportion of the these newly diagnosed HIV+ individuals who were put on ART within 7 days of confirmed diagnosis has been a key performance indicator of the quality of care in terms of the HIV care for each hospital. So we started to put everyone who newly received the HIV diagnosis to start ART within 7 days of diagnosis. And in 2020, the Taiwan CDC introduced the immunochromatographic testing, which could facilitate the confirmation of the HIV diagnosis within 30 minutes. So beginning in 2020, we started the same-day antiretroviral therapy. So over the past 4 years, since 2018, the percentage of individuals who newly received the HIV diagnosis and were put on same-day ART had been increasing. So in 2021, we estimate that about 56% of those newly diagnosed HIV positive individuals were put on same-day antiretroviral therapy. And another 27% put on ART within 7 days of diagnosis. So in total, there will be about 85% of those newly diagnosed HIV positive individuals start ART within 7 days of diagnosis. The other 50% probably will be either they were late presenters and presented with several opportunistic infections, which probably pose some challenges to start ART concurrently with other antimicrobial agents or concerns about cryptococcal meningitis or tuberculosis. So that's the current situation here in Taiwan.
Thank you. So shall we move on to another topic? Again, from 3 conferences. Also, I think that we have seen the data of the dual DTG-3TC very often, and longer sustainability in terms of a sustainable response, right, in terms of biological control, and also it's like regardless of the baseline 3TC resistance. It looks like the data showing that way. So the question is how this region have been thinking about this regimen, both in the naive population and the switch population. So what the pros and what the cons and what the concern, still having any type more evidence needed, or it won't be a preferred option anyway, because people still stuck with the triple therapy of the concept of triple therapy.
Yeah, and the future appears to be dual therapy everywhere, doesn't it? I mean, all the companies are producing dual therapy type strategies.
Right.
And I mean, okay, this dual combination with tablets, WHO have still not, I think the hepatitis thing and pregnancy and a few other things could be discussed about why aren't they adopting this. So that's one thing, and maybe someone from WHO could say why aren't they adopting it widespread. The second issue is that whether we like it or not, dual therapy, in principle, philosophically, looks like the way that the world's going. And the vanguard will be the injectables, but they won't. I think the injectables will be here for 3 to 5 years probably, and then we'll get some different modality of administration. But I suppose my feeling from the European viewpoint is that we're starting to think that the future is not going to be 3 drugs, for at least for initiators or people who are undetectable and want to switch. And I don't know how that would play into a session for you guys in Asia.
Yeah, I think yeah, a dual therapy for.
There will be a lot of interest.
Yeah. Please, Adeeba.
No, go on. No, I think there will be a lot of interest, but you know, everyone's still quite tentative. I was just sharing here that pricing is one problem, at least for the more upper middle income countries with DTG. And then the other, of course, is the higher prevalence of hepatitis in this region.
Right.
B especially, but all, yeah. So
in terms of switch,
I think,
in terms of switch, you already have data hepatitis.
Yes,
B.
switch certainly.
Switch, switch regimen maybe. Yeah. But I think in our Thai setting is that this if you use the 2-in-1 pill tablet, it's going to be expensive, and so we have to do it, and that you know, that the cons. People have to take 1 tablet of DTG and 2 tablets of the 3TC. So I think that it, you know, complicated.
In Korea, the most popular regimen regimens are Dovato and Biktarvy. In terms of 2-drug regimen with Dovato, there used to be some conditions for using 2-drug regimens, such as resistance testing, hepatitis B virus profiles, or viral load.
Viral load, yeah.
So we recently recommend rapid initiation, same-day treatment. So when we choose the 2-drug regimen, the conditions can permit the rapid initiations.
Okay.
Yeah.
All right.
Yeah, I mean, all this ties in well, doesn't it? Because there's been a rapid start with dual therapy that they've been doing a study. So you can see these late presenters, first day starting, dual therapy. You know, it all sort of intertwines into each other. So I think it would make a very good subject.
Yeah.
Yeah. Personally, I'm okay for using 2-drug regimens for rapid initiation in Korean situations, but there are some in the guideline. There are some conditions for that, but I'm okay for doing that.
And I think one of the things that you might discuss is what's the relevance of background 3TC resistance in dual therapy. I mean, I know we don't know the answer, but it's one of the things that a lot of people worry about. I mean, we have this issue with 3TC, with triple therapy, which most of us are relaxed about if there are 2 active drugs. But when you've got a dual regimen, does it become important again?
Right, right. Yeah, but with a small sample size data that a few studies have shown that might not be, doesn't matter in terms of baseline resistance. But I think, yeah, it need to see a larger scale of data in RCT. Yeah, I see your point. Yeah. Okay. So I think that in terms of long-term, long-acting injectable dual, yeah, as the Adeeba said, probably cost may be a major issue, and maybe even in the next 5 years going to be limited in a very specific population rather than majority of people. So what the uptake of dual long-acting injectable ARV in UK, Anton?
So we've got, you know, we have this group called NICE that have to authorize it. It's gone through that. It's now going through the local commissioning. In other words, whether or not local clinics can do it. And we're hoping to start this in the spring. So very soon for us. Well, I should say, spring's different all around the world. So around March, April time. And we've had a lot of interest from patients. I am keen, and I don't know if it'll be at CROI, to see the data on people who are very non-adherent, who have been given to oral pills, have been given this injectables, to see if that works too. But I think we're going to start with switch patients who are really adherent, who really want to go to injectables. I think that's how we're going to proceed, because we need to learn how to do this. And I think we want to do it in a very low risk population to start with.
The other long-acting study is the capsid inhibitors, really promising in the Capella, right? The Capella data in terms of, I think it's a small sample size, but it's a proof of concept that is very effective. But of course, you cannot go with monotherapy. You need at least one other active backbone. So the question is that so far, how is there any still a major concern of multi-drug resistant HIV in this region that really need or maybe a few or a significant number?
We don't know. Does any country do good surveillance? Yeah, I really don't think so. Yeah, unfortunately.
But at the clinics, I don't think Of course, I mean, our clinic is highly specialized, right? People well adhered. So yeah, we haven't seen it so far. Seen we used. I think even at the era of efavirenz triple therapy, that if well adhered people, we had to see a multi-drug resistant.
Yeah.
Not like 10 years ago. I mean, quite a number of them accumulating. Okay.
So I feel that the issue around long-acting injectables as ART in our region is probably different from high-income countries in a way that many people in high-income countries may see long-acting injectables as alternative options. But for us in low and middle-income country in the region, I think it will likely be positioned as like something for like the salvage regimen thing because of the cost. I think that's one thing, and the other thing is that many countries in our region are moving away from like visits every 2 months, 3 months to 6 multi-month dispensing, for example. So having every 2 months injection for ART could be something that kind of like go in the other way around of what we are trying to do. So I'm thinking that the investment in the infrastructure of the ART clinic could be something that like at a country level, if you are thinking of getting these drugs into our national drug list, it may not be that easy that even if we have the generic products, will that be something that we want to do at a national scale level?
Yeah, I think I have to agree with you there, especially, you know, if we've got the once a day pill, whether it's 2 drugs or 3 drug regime, you might find that patients, you know, are quite happy with that, with something that needs to be seen. I think the long-acting injectables probably hold more promise in our region as PrEP, right? Not PrEP, as prevention. Too, you know, so yeah.
Okay.
I don't know, how do you feel about that?
Right. Yeah. Let's move to another topic on weight gain. It's still more and more data coming in to confirm that DTG and TAF, particularly if put together, you have a significant weight gain with the average of, I think it's 2 kilo, right? One I have a 2 kilo per year. So I'd like to learn from Anton that it is really relevant clinically in Europe, because in UK, in our setting, we haven't seen a really a relevant problem in Asian population. But again, we have to see if we follow up longer.
Yeah, there is, but it's small.
Mm-hmm.
I think it's the same. It's about the same. I mean, when we look at this issue, it really is not. It takes up a lot of time, but it's that's the problem. It takes up a lot of time, staffing time, patient time, time for tests. It's very expensive, takes up a lot of time, but doesn't really. It isn't really a big part of our workload, but it ends up being that because of the disproportionality of how you've got to fix these patients. I mean, it's difficult.
Sure. Yeah. And
there have been some surveys recently. I think they may have been published in the last year around this. I can try and dig the slides out.
Okay. Thank you. Any striking, because I think in Taiwan you are probably one of the Asian country that have been started the DTG for a few years ago, earlier than other Asian country, together with Japan, I believe. Did you see any concern on the weight gain of TAF and DTG?
Yeah, yes, indeed. We did have dolutegravir introduced in 2016. But we didn't have sufficient data, the survey data on dolutegravir. But instead, in our hospital, we do have data on first generation integrase inhibitor, the boosted abitagrapir. Within 48 weeks of switch, the mean weight gain was about 2 kilograms. But with second generation integrase inhibitor, the bictegravir, recently we have the data showing that the mean weight gain was about 1 kilogram after switch from the other regimen to BF-TAF. About 5% of them had weight gain more than 10%, and about 15% of them had weight gain for more than 5% within 48 weeks. But the change of weight, I think, was not as much as we have seen in the published literature in the Western countries.
Okay, thank you. Yeah, thanks for sharing that.
So I also think
DTG very much, right?
I also think that most people, especially in Europe, I mean, I think it's happening in North America now, don't believe that these cause weight gain per se. They're not drivers. They don't actually make you put weight on. They just make your weight increase as it would be physiologically. Okay. And that efavirenz and Truvada are actually, there's a lot of data now coming through that they inhibit weight gain through various mechanisms, which not all of them have been done. And people then talk about abacavir, but there are two studies, one on mitochondrial fat and abacavir, which is a basic science study, and the second one, which we presented at EACTS, where people switched off abacavir to TAF, and the amount of GI disturbance disappeared. So the nausea and the poor appetite that people had, when you switch them to TAF, it disappeared. So it may be that a lot of these older drugs are working through gastrointestinal problems. I mean, TDF is a bit different because, you know, it's got a lipid effect as well, and we don't know what that bit is. So I think it's very intriguing, but I think the world's moving away, and that's why I said this occupies. It's not. It comes up, but then when I think about the hundreds of patients seen every day, it's usually that bit where a few patients have gained 10 kilos, and then everybody goes, oh.
Okay. Yeah. Right. Just a minority.
I remember last year Treatise published a paper on weight gain, and they showed that weight gain after initiation was associated with low CD4, high viral load, and INSTI-based regimen in Asian populations.
Right. Yep. You mean the baseline, right? The baseline. Yeah.
Yeah.
Okay. Great. Yep. Okay. I don't think I have anything else. The other one is the short course TB regimens. Adeeba, would you like to touch on that, please?
Yes, so I think in the last few years has been sort of quite a lot of interest in TB, thankfully, finally, whether it's latent TB or treatment. And the one that was presented at IAS, although it's also been published in the New England, is the Study 31, which looks at rifampicin versus the standard regime for 4 months, and it certainly is proven to be non-inferior, at least. So again, rifampicin-based regime is expensive in the region, so I'm not sure what the uptake is going to be like. Is it widely used in Thailand and other places?
No, we try to get it into the national essential drug list. I think we're in the process. Yeah, but it's not very expensive in Thailand. It's a lot of it's working on the generic form.
Okay.
Yeah.
Yeah, ours is still Sanofi.
I think you put your finger on it, Adeeba. I mean, the problem is, I'd love to know from WHO what the access to rifampicin is globally, because we can't get it in Europe, and what and what the access, who is accessing it. So what the access actually is, and who is accessing it, because it's fantastic to have this data. But I don't know what, maybe they have a plan to roll it all out. But I mean, it would be wonderful to know so we could prepare ourselves.
Yeah.
I mean, they'll exclude Europe, of course, fair enough, but not Central and Eastern Europe, they shouldn't. But Asia, they should certainly include in their plan for, and you talked about at the very beginning about drugs and medicine patent pool. What's happening with rifampicin in the region? When will we get it in the region? How should we start using it in the region? I mean, all of those. And every time I talk to people, everybody's going, well, no, we don't have it. So I don't know.
I didn't realize. I thought it was just us.
No, I think that they may have it in parts of Africa, but I'm not sure how well, because in Tanzania, where I do work, and Mozambique, I haven't seen rifampicin. It may be so-called available, but it may not be imported into the countries yet.
Yeah,
it may be too expensive.
They've donated it to us for a latent TB trial in prison. So that's about it.
Yeah.
I saw the data of NEJM, but in Korea, no one used 4 months treatment for TB. Every doctors use 6 months standard medications for tuberculosis.
Sure.
Yeah. I think in Taiwan, we do have experience with rifampicin, but mainly on the treatment of latent tuberculosis infection, so that the TBI. Since 2019, the Taiwan government implemented a program of providing IGRA testing for latent TB to every HIV positive individuals. So they hope to sort of to reduce the TB instance further among this at-risk population. So we now, since 2019, we have plenty of experience with either 1 HP, the 1 month isoniazid plus rifampicin, the daily, or 3 HP, the 12 weekly doses of isoniazid plus rifampicin for LTBI LTBI. So and particularly the second generation integrase inhibitor, either dolutegravir or bictegravir, these two regimen have been the major either the first line treatment regimen or the switch regimen. So we are now accumulating data on the drug-drug interaction between the second generation integrase inhibitor and rifampicin.
Nice. Yeah. Okay. Any other topic we want to discuss?
Another topic which was included in conference was vaccine response for HIV infected persons, COVID vaccine responses. Several conferences deal with the immunogenicity of COVID vaccines in HIV infected persons. In some papers showed the response is lower in HIV infected populations compared to general populations. Do you recommend a third booster shot for HIV infected persons?
Well, we have to
Yeah.
be careful with the terminology, I think. What's happened here is that there's a standard course, and standard course for HIV patients with a good CD4 count, more than 200, and the rest of the population who are not immune suppressed. So are 2 shots plus a booster. Now, a standard course for somebody who's immune suppressed with HIV or any other disease would be 3 shots plus a booster. So this terminology of booster tends to get a little bit confused.
The 4 shot, right?
Yes. Yes.
About that's 4
And
shots.
then
So,
just to confuse everyone more, the standard
Yeah.
course for the inactivated vaccines also 3 shots plus a booster. So if you immunocompromised and have had inactivated, what happens? Do you have 5 shots?
yeah. So some of that could be discussed. I mean, that's interesting. I mean, John Frater here from the UK have looked at people with good CD4s and looked at the immune response. There's been only case reports that I've seen in HIV of people with low CD4s where they haven't responded. But I think it's a great discussion point. And also, of course, there are other modalities now. There are 2 small molecules, one with ritonavir in it, which could cause a real big problem with co-meds. So that's, and they're also monoclonals. So I don't know what the availability are. So the management, so again, this is a toolbox for people who are managing patients. If you've got somebody with HIV with good immune function, good CD4, you might as well treat them with as usual, but then Adeeba's point about what is usual needs to come in.
All right, right.
And then those immune suppressed patients, what do you do? Okay, you can give them their course plus a booster, but are there other things you could give in case there's a non-response? How do you measure that non-response? I think, you know, because the T cells and the antibodies are both important, I think it would make a really good discussion. It's a great idea from my point of view.
Yeah. We're putting an abstract in for 2022. Rina has done some studies looking at HIV response immune response in HIV patients. Yeah.
Great.
Good.
Yeah, we need more data.
Yeah. Particularly different vaccine platform, right? You're going to see a really a big difference.
Just to confuse things even more.
Confusing, yeah. You may need 5 or 6 shots to get it up to, you know, the target. Okay, I think we cover more, right? Yeah. Anything else?
I was just thinking when Tony Fauci says follow the science, I see a maze. No way.
And that's before we start talking about, you know, how confusing is the rapid test versus the PCR to doctors, let alone to the public. You know?
Oh yeah. Okay. Anything else? I think that's it.
I think there's a lot of topics to cover. We'll go. It's like you have to have 2 sessions.
Very good, very good. Yeah. If nothing else, I think we can adjourn now.